Dr. Greg Costello, board certified family practice with CostelloWellness.com. I want to talk to you about the new thoughts on estrogen and breast cancer, but I've got a very important baseline we need to talk about first. That's the Women's Health Initiative. That was a study done in the early 2000s. They knew back then that women premenopause had much less heart attack and stroke risk than women postmenopause, and the assumption was that estrogen was protective against heart attack and stroke. So in this study, they gave menopausal women synthetic estrogen and synthetic progesterone and watched to see if there was more or less heart attacks, and indeed, they stopped the study early because women who took synthetic estrogen actually had a greater risk of heart attack and stroke when they were trying to prove the opposite, and they stopped the study early. The big issues with the study was they used conjugated equine estrogen, that is pregnant horse urine estrogen, a synthetic estrogen. They used a synthetic progesterone in women that had their uterus so they wouldn't get vaginal bleeding, and it turns out that they had more heart attacks and strokes. The other take-home message is that the longer you had been in menopause with no hormones, the greater your risk of heart attack or stroke. So someone who was 50 and just started on hormones had less heart attack risk than someone who had 55 and had not had hormones for 5 years. That first year of hormone replacement was the most dangerous, and after you were on medicine for a year, your risk came down closer to baseline, but still an overall increased risk. So if you're going to take estrogen replacement, you obviously don't want to use synthetic estrogen. The example is when you're taking birth control pill, that's synthetic estrogen, and your gynecologist in your mid-40s tells you you have to stop taking the pill because it increases your heart attack and stroke risk. And then at 50, when you get menopause, they put you right back on synthetic estrogen. It doesn't make sense. The other issue is that you never want to take estrogen, even the correct bioequivalent estradiol. You don't want to take it by mouth because of something called first pass phenomenon. When you take any medication by mouth, it gets processed by the liver, and about 95% of that estradiol gets converted into inflammatory molecules and prothrombotic, or molecules that actually cause blood clots. So you want to avoid the mouth for estradiol. So if you're going to take it, make sure it's estradiol. Make sure it is either a patch that you put on twice a week, or come see me and get a pellet under the skin every 3 months and bypass that first pass phenomenon. The other very important thing is that if you have your uterus, you have to take progesterone. Otherwise, you're going to bleed and may get cancer of the lining of the uterus. So you want to make sure you don't take synthetic progesterone, which is spastic. It actually causes vasoconstriction of your blood vessels. You want to take natural or micronized progesterone, which is vasodilatory or opens up your blood vessels and protects you from a heart attack. Now, the way that micronized progesterone is made, it actually can be taken by mouth and doesn't have that same first pass effect. So if you're going to take estrogen replacement therapy in menopause, you should make that decision right when you go into menopause. Don't delay it. You want to make sure you're taking bioequivalent estradiol, not conjugated equine estrogen or synthetic estrogen. You want to make sure you take that estradiol as either a patch or as a pellet under the skin, not as a pill. And lastly, you want to make sure you take that progesterone as micronized progesterone at bedtime and not the Provera or the synthetic progesterone. So if I get to it soon, we're going to do that estradiol or estrogen and breast cancer video.